Well, we wanted to give plenty of time for audience questions today, so we're going to go right into that. If you'd like to ask a question, please raise your hand and wait to be acknowledged. And then we do ask that you speak loudly, introduce yourself and your organization, and then please try to be brief. We want to make sure that as many of you can get your questions in today as possible. I'll also repeat your question so that everyone in the audience and the panel can hear. So, who has a question? Yes. Right back. Thomas, do you want to take that one? Oh, I'm sorry. You're right. I apologize. So why would Missouri choose not to expand its Medicaid program?
I'm looking around for my boss. Let's see, is he here?
He's right there.
Idiocy. There is absolutely no reason not to expand Medicaid. So Ryan touched on dish payments. Hospitals want it. Providers want it. There makes absolute no sense to not expand Medicaid. We also get to reach the population that needs health care. We are able to save money down the line because people are going to have access to a primary care home. They're going to have access to preventative care. I mean, there are no plausible reasons. Now, there's some discussion about the economy. How much will this cost? And the federal government is going to pay for the Medicaid expansion in the first 2 years at 100%. They are then going to drop down to 95% for another 2 years, and then after that, they will pay 90% of the expansion. When you think right now that the current Medicaid match is 60-40, that the federal government pays for 60 cents on the dollar, this is going to be 100%, 95%, and 90%. Just by way of numbers, that means that if Missouri put $480 million into its Medicaid program, this expansion program, they will get nearly $8 billion in return. There makes no sense, both from a health perspective as well as an economic perspective, as well as, and Ryan made the point about your businesses. If you right now are looking at paying premiums that are going up, there's very little in this law that says that premiums are going to be held at an affordable rate. If you do not expand Medicaid, if we do not as a state, it makes that possibility of affordable premiums even less, because more of the cost shifting that this law saves money from eliminating will occur, and as that occurs, your premiums will go up as business owners and as employees and or purchasers.
And I would just add one other thing, too, is that it is your tax dollars that are going to be paying for Medicaid expansions in other states. So it's not as though if Missouri turns down the money that Missourians get a break on their federal taxes. In fact, your tax dollars just go to support Medicaid expansions elsewhere. So I owe the lady in white a question.
My name is Karen Kalish. I'm HomeWorks, the teacher home visit program. And Ryan, wherever Ryan is, said costs and prices at the hospitals will go up, and therefore, I heard that therefore, there will be an increase in private insurance. So why don't the hospitals have to look at how they can cut costs?
I like this question. Ryan, so the question is, why don't the hospitals have to look at their own operations and think about how they can cut costs to try to make up some of that difference?
And I think they will, and they are. I mean, we recently did a report on, actually with the St. Louis Business Health Coalition, on charity care in Missouri, at Missouri hospitals, and we examined, I think it was like 10 different counties, hospitals in different counties, and we looked at overall profits. And Missouri hospitals are doing okay, but some of them are actually negative revenue, and then some of them are, the average is like 4% profit margin. So the dish funds that hospitals get does not pay for the entire amount of what it costs to care for the uninsured. It's a portion. And so if we are losing all these dish funds and we still have all these uninsured, the hospitals will not entirely cost shift that full amount onto the private insurance. There would be too much pushback. So I think it will be a multi-pronged approach. I mean, I think if we had hospitals up here talking, they would say they're looking across the board at where do we, if we don't have Medicaid expansion, where do we make up for those costs, and how do we continue to pay for the uninsured that are walking through our doors? So I think it will be efficiencies within the hospital. There will be some cost shift onto private insurance, and there are still some DSH funds coming into the hospitals.
So if you get to page 200 or 2,200 of the law, if you get that far, you're going to get to what's called bundled payments and accountable care organizations. And Tim can maybe speak to this just a little bit, but these are asking hospitals to act like HMOs, but with doctors in charge of the decision making. They're saying, listen, you have to become more cost effective. You have to do many things, including reducing preventable infections, including better billing, including strategic decision making. And you have to do this in exchange for a bonus payment. So you will make more money from Medicare if you begin to become more efficient and more effective. And this law is trying to ratchet down some of the costs of care. But if we begin to think about some of the holes in this law, one is keeping down the cost of premiums. There's nothing in this really. There are a couple of components. I mean, people in this audience may have gotten checks from the medical loss ratio. When an insurance company doesn't spend enough on actual care, they have to return back those monies in the form of a check or a rebate. Those are to keep premium costs down. But to get to the cost of care, this law doesn't have many levers at its disposal other than Medicare. And Medicare is trying to aim at making hospitals more cost effective. So it is in here.
Doctor, let me just add to that comment, in that in addition to the cost effectiveness, a part of the ACO concept really does address quality as well, because it addresses issues of transition of care, for example. Because the hospitals and the primary care providers along the continuum of care for the patient are in it together, so that transition, right now, that's where a lot of the losses are in terms of quality for patients, when patients move from one environment to the other. So the investments that were made in actually preceding the ACA, but in the stimulus, were investments in health information technology, which allowed for those transitions, hopefully, to be able to occur more efficiently and effectively, and therefore have a positive impact on the quality of care that the patients receive.
Dr. Peck.
Bill Peck, Washington University. Tom, will subsidies be permitted if the federal government establishes your state exchange rather than the states themselves?
I'm just going to repeat the question really quickly. So, will subsidies be permitted if, depending on the exchange structure, whether it's federal or state?
Subsidies will be permitted. Subsidies are an integral part of this law and getting more people to be able to purchase insurance.
The reason I ask is because it's been challenged, because the way the law reads, it's only state exchanges, state-run exchanges.
The regulators themselves have come out and said, we made a mistake and we really meant that to be for both. We do expect that there will be some legal challenges to that, but our guess from our legal resources is that it will be upheld. We'll have to wait and see, but it...
All right, let's go to the gentleman in the front here.
Yes, my name's Kurt Lord. I'm with Lord Medical Real Estate, medical real estate brokerage in St. Louis. I wanted to follow up on what Thomas had said. You said that this is going to put the doctors more in charge, but I'm curious about that statement because it seems like there are penalties to the hospital systems for readmissions. So in actuality, wouldn't the doctors be less in charge, and isn't it a catch-22 because of lack of tort reform? So the doctors end up ordering a lot of tests, or they get scared, and they're not really in charge, but if they get a readmit, then they're not going to get compensated for the first admit.
So I think that the question is really, does the law actually put physicians in charge, particularly in the example of penalties for high percentages of readmissions? And also, I think more broadly in the other delivery system reforms.
and I thought I was going to be able to hide on a panel. Are doctors more in charge? They are. They are more in charge. Let's just get to something that was mentioned earlier, the electronic medical records. There's a sense now, and again, to defensive medicine. Lots of unnecessary tests are ordered. They're ordered because of a fear of lawsuit or a number of institutional incentives to repeat those. With electronic medical records, with some of the reforms in this law that are aimed at empowering physicians to make decisions about quality, best practices, etc., I do think that physicians are in charge. Is this law about empowering physicians to make decisions about your health care? No, this law is not about that. This law is about getting more people health insurance. This law is about getting people to the doctor earlier and more often and saving money through prevention. You point out very interesting institutional kind of rub. So you have physicians who are essentially prescribing care, and then you have the institutions or administration and or the federal government assessing penalties on the basis of performance that maybe a physician is not in control of. When we look at pilot projects of Medicare, when we look at pilot projects throughout the state, these ACOs were pilot projects, these accountable care organizations were pilot projects. When these pilot projects take place in micro or in small settings, physicians feel empowered because they are able to talk to their hospital administrators and say, I have to be able to follow this course of practice to cut down on the number of infections, to cut down on whatever those negative metrics are. So to say generally, stereotypic, this law is a boon for physicians. It's only a boon for physicians because more people are going to have insurance and more people are going to be visiting their physician. But when we think about it from an organizational perspective, physicians will be empowered to have higher quality and better outcomes so long as they are empowered through what the federal law is requiring of their hospitals.
And there are actually a number of very good organizations that have followed this model that have had really good success. Geisinger in Pennsylvania is one. Advocate up near Chicago is another, where they have worked together to deliver seamlessly care across the board and have, in many cases, a bundled payment with incentives in the right places, and they've gotten great response in that. I just read an article yesterday about a reservation up in the Northwest who had delivered care very poorly in the past, and they basically put together an accountable care model. They didn't call it that, and they have had significant reductions in costs. Emergency room visits are significantly down. Outcomes are improved. Readmission rates are much lower than they had been. So the model will work. And I'm anxious to see more of these ACO models, even if they're just for Medicare right now, pop up, because I think that's going to flow through to the employer community for delivery of health.
I want to give Dr. Craig a chance to weigh in as a physician who's practicing. What do you think about this?
Yeah, I would just reiterate everything that's just been said, because, I mean, in fact, again, I think the ACO model really is going to allow the opportunity for quality to be preserved and enhanced, in fact, and also to realize those cost savings. Because, again, you have a group of people across the continuum of care who are all invested in the same thing. So, and the improvements in health information technology will, again, allow for some of those cost savings, as well as, better communication and more power. So, yeah, I agree.
Before we go out and give a hug to our ACO physician, let's be truthful. The Department of Health and Human Services has not been very clear on what it takes to become an ACO. They keep issuing regulations and new regulations and having question and answer periods. So when we say, listen, this is a great idea, ACO, let's put it in there. The law is only 2,400 pages. Were it to have gone through every specific component of an ACO, it may have been 1,000 or 2,000 more pages. So we aren't exactly sure beyond the conceptual level, what does an ACO look like? Now there is a Mercy hospital that did an ACO pilot project in Lebanon, Missouri, and you know what? The physicians are happier, they have better outcomes, and it's been very successful. And the CEO of the hospital was like, you know what? It works really well. Does this mean that it'll work really well across the system? We don't know. We still are waiting as a country and as participants in the healthcare system to know exactly what does the ACO look like on a global perspective.
And it's not a new concept. I mean, go back to the early 90s, our first iteration of healthcare reform, and there was the integrated healthcare system, or the integrated health system model, and it really is the same as the ACO. It's a new title, so it's a further development along that same concept. So I think that we've got some experience to work from. We've got models within the country in different pilot programs. So I think the value has been proven, and there's great opportunity here. And yeah, we're going to have to see how it all rolls out on a national level, but I'm very, very hopeful.